Okay. The SARS-CoV-2 virus, very well, that is majority of patients or usually person with the mild. Okay. And most of the patients are able to develop the sufficient appropriate immune response leading to the virus clearance from the body. But however, significant subset of the patients can get the severe, the severe the clinical presentation, like they can 14% can go for the severe pneumonia, or 5% can develop into the acute respiratory distress syndrome. Okay, that's why the name itself called SARS-CoV. Okay, another is can go for sepsis and multi-organ dysfunction and failure. The SARS-CoV-2 virus, they consider mainly 4 important the structural glycoproteins. That's the spike protein. This is a spike protein. This is a crown-like. Because of the crown-like, this is called as the coronavirus. Okay, and the spike consists of the S1 subunit and S2 subunit. You know very well. Between the receptor binding domains also. Another is the membrane protein, the E for envelope protein, N for nucleocapsid proteins. Okay, and the ME1 and the 3 proteins are important in the viral particle assembly and release from the host cell. The S protein is most important for the viral binding to the host cells or entry into the host cell. The corresponding the S protein and the E protein, N protein are detected in the RT-PCR. The genes are detected. Okay, the S protein also most important for the already are told that the vaccination development. This is also one of the antibody development, neutralization antibody development is S protein is important. The COVID-19 pathophysiology consists of the 4 important steps. First is the how the viral entry into the cells, how the host immune response to the SARS-CoV-2 infections. Another is the what is the hyperinflammatory space development, what is the cytokine storm syndrome, mainly the multi-organ dysfunction. You know very well that the SARS-CoV-2 virus infections mainly transmitted to the respiratory droplets and the fomites. Okay, the mainly affect the upper respiratory tract, followed by lower respiratory tract. Usually after entering into the cells, they will affect the nasal ciliary epithelial cells and the alveolar cells. That is a type pneumocytes, type 2 pneumocytes. For SARS-CoV-2 infections, need the phase receptor. That is the receptor is the ACE2. That is human angiotensin converting for entry of the receptors. Okay, this is the ACE2 receptors. First, there is a SARS-CoV-2 infections by the S spike protein will attach into the ACE2 receptors. For entry into the cells, they need some proteases like enzymes for cleavaging of the exclude domains. That is called TMPRSS2 proteins, proteases enzyme. That is called transmembrane serine proteases 2. Okay, this isn't here. Okay, and the SARS-CoV-2 virus infection and the specific like furin like cleavage sites also they are located in between S1 and S2 subunits. This act like a furin like places. This also in the that cleavaging of the S1 S2 domain leads to increased transmission of the virus into the host cell. The ACE2 receptor mainly expressed in the lungs, the alveolus, and the ciliated epithelial cells. Microbials are already told everything. S2 domain, this corresponding genome expressions. This is the S1 domain, S1 domain. This is receptor binding domains. In this furin cleavage site in SARS-CoV-2 virus, specifically in 4 the amino acid the mutations occurring. Okay, that the transition mutations occurring. So RPPA mutations. This is the highly helpful in the transmission of the virus inside the cells. Also increase pathogenesis. Apart from lungs, that ACE2 receptors mainly expressed in the heart, small intestine, stomach, kidneys, thyroid, adipose tissue, and bladder, also in endothelial cells. The ACE2 receptors mainly expressed in the endothelial cells is important because of the SARS-CoV infections leads to development of endothelial cell damage during the pathogenesis. How the life cycle of SARS-CoV-2 virus infection occurring. After binding of the SARS-CoV-2 infection by spike protein into the ACE2 receptors into the cells, after that they nucleus counts, the nucleocapsid enter in The cytoplasm of the host cells, they will integrate into the host with the help of the ribosomes and the end of cellulose reticulum, the RNA replication occurring and translation occurring. It's development of the SARS-CoV-2, development of SARS-CoV-2 cellular proteins, the accessory proteins, they will form the virus vesicle. The virus vesicle, they'll uses the membrane, the development of the full viral formations, they release it into the circulations. Again, they will infect the other cells in same fashion. Okay. After they released from the cells go for a death. Okay, the death mechanism is usually occurring in the mechanism of apoptosis. That's called here there is a pyroptosis mechanisms. After the death of the cells, they will release this certain substance into the circulations in local tissues. For example, dams, the proteins and the proteins. Dams means that damage associated molecular patterns and the pathogen associated molecular patterns. They release it into the local site. That the substance will recognized by the cells in the local site. By example, macrophages, endothelial cells recognized they having the particular receptors. That's the receptors called toll-like receptors. The toll-like receptors, they recognize the PAMs and DAMs proteins. There may be extracellular, intracellular, leads to the synthesis of the certain substance, that is cytokine schema synthesis. That is called type 1 interferon or interleukin 1. Interleukin 1 from the inactive into the active interleukin 1 secreted. They will act on the virus. They will stimulate the antiviral response. Okay, the interleukin 1 increased in COVID-19 infections in the local inflammations. If there is no systemic involvement, interleukin 1 will be raised in conditions. Okay, 1 minute, the people are coming. I will admit.
Sir, you're not audible.
Yes, I'm audible. The people are coming. I admit it. One second. Okay, 1 second. Can you admit all people, please?
We'll do that, sir.
Okay, sure.
Continue with the presentation.
Yes, thank you. After that, SARS-CoV-2 infections, first they will infect the isolated epithelial cells and alveolar time. The alveolar epithelial cells, okay, infection. The substance already told the type 1 interferon in interleukin 6. Okay, this substance they will stimulate the macrophage and dendritic cells. Sometimes the virus itself, SARS-CoV-2 virus infection directly infect the macrophage and dendritic cells in the okay alveolus. They will release a certain substance for MCP1, the macrophage chemotron protein, the MAG, okay, the macrophages immunostimulating proteins, okay, IP10. This also will release the activation with T cells. Sometimes this is the macrophage dendritic cells or act like a antigen presenting cells. From then that after the SARS-CoV-2 infections, they will present the antigen into the lymph node. From the lymph node, the process of occurring when the specific T cells are produced from the end. That T cells from the lymph node, they reach the lung, like a local site of the injury. Okay, that is called the cytotoxic antigen specific T cells. They enter into the local site of inflammation lung. They will remove the infected cells. Slide is not moving. Okay. The various the cytokines, chemokines are produced during that inflammations or interleukin 6 highly elevated in the local site of inflammations. The other is interferon and a monocyte chemoattractant protein and the interferon gamma induced proteins are increased during the inflammations. After that activation of the in the lymph node, the cells they produce the two type of immunity. It is a first there is a cell mediated immunity or there is a humoral mediated immunity. Okay, that cell mediated immunity they consist of the CD4 cells development and the CD8 cell development. The CD4 cells they activate the and B cells they produce the antibodies response. The antibodies will cause the antibody neutralization and the clearance of the infections. Okay, during that antibodies is mainly you are going to see the spike receptor domain antibodies. Okay, you can assess the immune status when the vaccination or infection can do the receptor binding antibodies also. Another is the CD8 cells are also produced during the cell-mediated immunity. The CD8 cells are cytotoxic T cells. They specifically act on virus cells, infected cells. They destroy the virally infected cells, the clearance of the infection. Next is the how the hyperinflammatory space occurring. Okay, what is the cytokine storm syndrome occurring? During the cytokine storm syndrome, that there is increased pro-inflammatory cytokines and chemokines in the body. Okay, why there is occurring means there is a excessive infiltration of immune cells in the lungs, allowing there is a increased all pro-inflammatory cytokines, chemokines because of the the immune dysregulation. Why there is immune dysregulation occurring? We are going to discuss. Okay, because of the rapid viral replication, okay, and the viral infection and cellular damage occurring in the lungs, mainly they affect the epithelial and endothelial cell damage, leads to the vascular leakage and inflammation at the alveoli, leads to development of ARDS. Because of the epithelial cell and endothelial cell damage, they will stimulate the increased inflammations occurring in the local site. Also, because of the epithelial cell damage, they leads to the in all inflammatory cells recruitment to the site of injury, leads to the increase in this of the or pro-inflammatory cytokines, chemokines. This is a vicious cycle. It leads to increased inflammation at the local site of inflammation. Leads to all the inflammatory mediators will be raised. For example, interleukin 6, the mainly increased GSF. Slide is not moving. Okay. The interleukin 6 mainly another is tumor necrosis factor increased, and the GCSF granulocyte factor also increased, IP10. All the macrophage inflammatory proteins are increased because of the T cell mediated immunity, the Th1 T helper cell 1 and 2 cell response. Okay, the interleukin 6 is the cutoff value for 55 or 80 from is the to assess the risk severity of the patients having the patients in COVID-19 infection. This is histology showing infections. We are going to see the hyaline membrane formation, fibrin plaque formations with excessive immune infiltration of the cells, okay, inflammatory cells infiltrations, okay, edema also around the lung. This is the alveoli. Here it is. During the cytokine storm, there is all acute inflammatory markers will be raised. For example, C-reactive protein and proteins also there is a raise in the serum levels. Okay, there is a decreased lymphocyte count. Why there is a decreased lymphocyte count? Because of the T cell activations. Okay, allowing there is a increased neutrophil count in the body. The relatively increased neutrophil count also. This is assessed by the neutrophil lymphocyte ratio. This is useful to assess the prognosis of the patient in management also. That this is a neutrophil lymphocyte ratio will assess the usually NLR ratio, that is more than 3.13 means patients going for the critical illness have to need to be admitted, okay, in the ICU. Okay, what is the mechanisms? There is a developmental lymphopenia, means because of the T cell there is a decrease in the peripheral circulation. Because of the T cell usually redistribution, the migrated from the circulation into the lungs, leads to the T cells will be decreased in the peripheral circulations. We are going to see as a lymphopenia. Okay, another is the tumor necrosis factor also induce the apoptosis in case of in the lymphocytes, leads to the lymphopenia. Okay, another is maybe SARS-CoV-2 infections also directly infect the cells, leads to cytopathic injury also. The T cells leads to the lymphopenia occurring. The slide is not moving. what is the coagulation in case of SARS-CoV-2 infections? SARS-CoV-2 infections, there is increased both, okay, the all APTT also and the prothrombotypin also activated partial thromboplasmids both are increased. Along there is a increased elevated D-dimer because of the thrombosis mechanism occurring in the SARS-CoV-2 infections. Along there is a less patients, the very rare patients can develop also thrombocytopenia also, because in all autopsy patients, from the 87% patients, they have developed the fibrin thrombi in the pulmonary small vessels. This is a fibrin thrombi in alveoli. Okay, small cells they having fibrin thrombi. This is alveoli. Okay, suggesting that hypercoagulability occurring in the severe COVID-19 infections because of the diffuse endothelial cell damage. What is the mechanisms leads to hypercoagulability in case of COVID-19 infections? Means because of they will activate the complement pathways activation leads development of the coagulation cascade. They will damage the vascular endothelium. Endothelial cell damage because of the ACE2 receptors highly expressed in the endothelial cell damage. They infected by the SARS-CoV-2 infection leads to the increased vascular permeability and the vascular damage also. Also the recruitment of the monocyte recruitment leads to the activation of the tissue factor leads to the blood coagulation will be increased. What is the role of neutrophil extracellular traps? What is the NETs? Okay, this is an neutrophil extracellular traps. This is decondensed protein material released into the circulations. Usually, this is the trap material. Usually, that bacterial infections, the bacterial infections. And this is the NETs also. They will lead to the thrombosis. Okay, during the conditions, there is a microperoxidase DNA and proteins are highly raised to evidence the occurring in our body. Okay, this is the photograph showing that Tamil Nadu CM are being inspected our hospital. Okay, this is the how the SARS-CoV-2 infection progress into the multi-organ systems. Okay, the severity of the SARS-CoV-2 infections assessed by the into the multi-organ system dysfunction. Okay, these will affect the CNS and heart and kidney, liver and gastrointestinal tract. Usually they will all the inflammatory mediators along with the enzymes are elevated during the multi-organ system involvement. Along with the other organs, the other organs, the vascular system also affected leads to development of thrombosis and pulmonary embolism also. In cardiac also the tocosobocardiopathy. This means that is induced cardiopathy also. Okay, another is the myocardial injury and myocarditis, cardiac arrhythmia can occur, cardiogenic shock, myocardial ischemia, and acute cardiomyopathy also can develop. Okay, the tocosocardiomyopathy, myocarditis, and acute cardiomyopathy occurs because of the respiratory failure and apex induced also. The endocrine system also they affected. It's glycemia also. The pancreas also affected because of the other also hyperglycemia because of the drug intake, the steroid intake also there is hyperglycemia. Another is the diabetic stress development the disease also. Another dermatologic manifestations can occur in this SARS-CoV-2 infections also. This is the morbid rash after the COVID-19 infection. Okay, this is the affecting the trunk and the lower limbs. You are going to see the morbid rashes. This is one of the most common signs after the COVID-19 infections. This is morbid rash can occur after the vaccination also. In histology, you are going to see epidermis. Epidermis, you are going to see the vesicle formation, spongiosis, and the basal cell degeneration, vacuolation. So you are going to see this is a vessel perivascular. The lymphocytic infiltration along with this the small tiny vessels having thrombosis. This is a feature of the morbilliform rash after COVID-19 infections. Other the perineal like lesions also can affect the feet, hands, the tip of the fingers and the feet they affected. This is like burning sensation because of the like almost necrotic ischemic like lesions, perineal lesions. Usually, sometimes the early presentation of perineal like lesions later on they tested for COVID-19 positive also. Okay, they can develop vesicular arterial lesions also, microarterial lesions also. They can develop purpura and fatigue lesions. Can manifest skin manifestation also. Cardiovascular system the affected in SARS-CoV-2 infection means because of the excessive immune infiltration occurring in the lungs and cardiac muscle, they leads to development of the excessive and the cytokine directly affect the cardiomyocyte also leads to the endothelial dysfunction. Along with there is a during the cardiovascular injury, they say cardiac troponin and the BNP, brain anatripiprid, and NT-proNP, all the inflammatory materials are increased because of the myocardial injury. Along with there is an elevated CRP, 30 interleukin 6 also. Because of the SARS-CoV infections, there is no sufficient evidence that directly the SARS-CoV infection affecting the cardiomyocytes. Okay, the endocardial biopsies told mainly in the excessive immune cell infiltration in the myocardium. How the kidney affected, renal injury. Okay, because of the ACE2 receptors highly expressed in the kidney. Okay, and the renal tubular cells, directly SARS-CoV infection directly affected the renal tubular epithelium. They will lead to development of mitochondrial dysfunction, the acute tubular necrosis, and protein leakage. Okay, leads development of from the mild proteinuria to the minor serum creatinine and urea. Leads development of acute kidney injury and acute renal failure also. Also, they will cause the thrombosis and ischemia, leads to further damage to the kidney tissue. How the gastrointestinal tract is affected? Because of the gastrointestinal symptoms, usually when the patient's present nausea, vomiting, diarrhea, abdominal pain. The SARS-CoV infections mainly because of the ACE2 intestinal epithelial cells, also they affect the intestinal enterocytes also. It's mainly a dysfunction occurring in the ileum and colon. Okay, that in stool you are going to see the COVID-19 mRNA materials are released in the stool. You are able to see, but there is no evidence that the stool is the transmitted the SARS-CoV virus to other people. Okay, liver also affected in SARS-CoV infections. Along with there is a liver injury, because of the liver injury there is a enzymes are elevated, AST, ALT level are elevated. Okay, that SARS-CoV infections mainly affect the bile duct epithelium, leads to bile duct injury. Okay, along with there is a bilirubin also, there is elevated also. Maybe the drug taken also affect the liver cell injury. For example, the remdesivir also they will take a liver cell injury. Other drugs also, the proteinase inhibitor drugs also. Hypoxic also, along with the cytotoxic T cell mediated necrosis also can affect the liver cells. What is the pancreatic manifestation of the SARS-CoV affected? Okay, the ACE2 receptors already affected, expressed in the both exocrine and cells of the pancreas. Okay, because of the exocrine pancreatic injury, there is elevated amylase and lipase levels. Few patients they can develop into the acute pancreatitis also. Okay, there is a suggested that in pathogenesis, the immune mediated destruction of the beta cells also can develop because of the excessive immune infiltration occurring in the pancreas also. Okay, because COVID-19 are always the NNC complications of the diabetes. And understand how the central nervous system affected. In case of COVID, SARS-CoV is the patients usually person with the headache, dizziness, confusion, epilepsy, ataxia. Ataxia means the involuntary movements. The altered sense of smell can a person with around 80%. Loss of taste also. In a very low percentage, you can get the Guillain-Barré syndrome. They affect the spinal cord also. Okay, altered sense, the altered sense of smell used commonly in the beta variant of delta variant of SARS-CoV. You are going to see in Omicron virus, usually you can get in the 10 to 20 to 15% only. Okay, in the altered sense of smell and loss of taste. Okay, usually affecting the young females. What is the mechanisms the sinus is affected? Because of the ACE2 receptors express endothelial cells, because endothelial cells damage also leads to development of sinus affected. Also there is cause, they will cause the neurological edema along with brainstem compression. Because of the, they will cross the blood-brain barrier. There is a concentration of the SARS-CoV infections, you are going to CSF level will be raised. Okay, along with there is a hypercoagulability conditions also. Along with there is a chemoreceptors lung affected, leads to the propagation of the affecting the CNS system also. How the pediatric populations affected SARS-CoV means, usually the pediatric populations affected is very mild because of the is underdeveloped in the pediatric lungs, pediatric cells also. Okay, the rare cases in pediatric populations they can go and then they go for severely affected. They present with the toxic syndrome. The patient present with shock. Okay, the patient having abdominal symptoms, diarrhea, nausea, vomiting, everything symptoms also. This is called multi-system inflammatory syndrome in children. Okay, MISC. Okay, this also the person with this Kawasaki disease also. This one of the is also the person with the variant autoimmune disease also. Okay, this is the first case reported in the April 2020 in UK. What are the manifestation of the how to diagnose the multi-system inflammatory syndrome in children? Means patients having persistent fever in children. Along with the patient developing stomach pain, diarrhea, vomiting, and the conjunctivitis, headache, have to refer the patient to pediatrician. How to diagnose the MISC syndrome means the multi-system inflammatory syndrome in children means the patient is having the fever more than 3 days. Along with there is a rash, any two of the features, rash, hypotension, shock, the myocardial dysfunction in case of pericarditis already can develop. There is elevated coagulopathy, PT, APTT also in this, along with the D-dimer they will be elevated. The gastrointestinal symptoms also you can see. Along with there is in the inflammatory markers will be raised, or ESR will be raised, C-reactive protein will be raised, procalcitonin will be raised. After there should not be any infection like staphylococcus infection, and streptococcus infection should not be there. Along with there is evidence of the recent coronavirus infection would be confirmed. This go for the syndrome diagnosed by the multi-system inflammatory syndrome in children after treatment immediately. How the pregnancy people affected because of the SARS-CoV-2 infections means this is the fortunately that pregnancy people affected the same like that of the non-pregnant people in hereditary age group. Okay, there is a less mortality also because of the immune adaptations occurring in the pregnancy during pregnancy leads to development of the leads to preventing development of hyperinflammatory states in the COVID-19 infection. Okay, there is always possibility of the miscarriage preeclampsia. Means preeclampsia means hypertension occurring in the pregnancy. Always association with the usually association in the SARS-CoV-2 infections because of the SARS-CoV-2 infections affecting the placenta involved. There is no evidence suggested that vertical transmission means the infection SARS-CoV-2 infections from the mother to the children during delivery also, after delivery also, in placenta and in uterus delivery also, there is a possible is very low, unlikely. This is one of the interesting case. One of the 43-year female having the SARS-CoV-2 infections, they have been presented with the nose with middle meatus necrotic biopsy. They given to the Department of Pathology. This is the showing the excessive immune infiltrations along with necrosis. You are going to see this is the broad septate. This is broad septate. Hypo also you are going to see. This is broad septate with broad non-septate with branching at right angles. This broad septate. This is when you're going to see broad branching at right around 90-degree angles. This is a PS positive. Also, this should be a mucormycosis diagnosed. Okay. Usually, because of the immune media dysregulations, mucormycosis infection also can occur in SARS-CoV-2 infections. This is the angio invasion. Okay. And the neural invasion also, bone invasion also can affect the sinus also. Okay. To carefully treat this patient. Next is in Omicron virus in the WHO designated as this is the Omicron virus as a variant of concern in November 2000. Okay, November 26. Already discussed in microbiology what are mutations occurring in the Omicron virus. Around more than 50 mutations occurring in the genome. Mainly the 30 mutations occurring in the spike protein. Okay, because the spike protein mutations already all told. Okay, S gene dropout or failure can occur in the artificial. Okay, if there is a S gene dropout or failure means most likely Omicron. Okay, and there is no confirmation. I have to go for the gene sequencing. Okay, because of the S gene dropout or failure can occur in the very few cases of Delta variant of coronavirus also. That's why S gene dropout failure are most likely a Omicron virus. Another is N gene dropout also again there. Okay, in Omicron virus, there is a because of the a spike protein mutations. There is increased transmissibility of the Omicron virus can occur. Immune escape mechanisms can also affected. What are the site usually most common mutations already saw everything told covered. Okay, just receptor binding mutations or furin intelligent mutation also. The entity antigenic superset mutations also can occur. This is the 3 mutations occurring in the receptor binding mutations. Okay, most important 3 mutations. Okay, 4 and 7 position. Lysine to asparagine mutations on the glutamine lysine substitution also, asparagine to tyrosine substitution also. Three important mutations. Okay, most important they will escape in the immune system. Another is N501 mutations. It's also most common in the alpha beta and gamma variant also, coronavirus also. Because of the mutations, there is increased binding capacity of human receptors also, ACE2 receptors. Okay. Another is there is a linked increased risk of infection and transmission also. Okay. Because of this 498 mutations occurring in the glutamine substitution, there is increase the ACE2 binding. The affinity is more than fold. There is increased in Omicron virus. Along with the alpha beta and the Omicron virus also position that 681 position, okay, leads to the inferior cleavage site. There is increased transmission of the virus because of the inferior cleavage site. There is a cleavage of the S1 protein. There is increased transmission of the facilitated the transmission of the virus to the host cell. Finally, the NTD, nanotine suppressor, the N domain of the spike protein. Okay, this is first they infect the cells. First, will touch the host cell membrane. This is a site usually for the antibody recognition attack of the for the host cell immune cells. Okay, usually because of the mutations occurring in the four important the places from the 142 145 the sign. This is the mechanism needs help in the immune escape from the our host cell immune cells. 142 the position mutation also common to the delta variant of the coronavirus also. How the pathogens of Omicron virus is the Omicron virus usually multiplication occurring in the bronchus usually more than 70 times compared to the other variant of the coronavirus, for example, Delta virus variant also. Another is this is the replication of the Omicron virus in the lung is the very 10 times less than the okay other virus variant also. That's why this is the Omicron virus is the severity is very low compared to the other coronavirus variant also. Another is the that coronavirus in the lung tissue, the ciliated epithelial cells also usually affecting the upper respiratory tract infections. Upper respiratory cells mainly affected. The alveolar cells usually not affected with the Omicron virus. Okay, that's why you're going to get more symptoms in the upper respiratory tract symptoms, not in the lower respiratory tract symptoms. The ARDS development also very low in case of the Omicron virus. This is the immunohistochemistry with Omicron virus in the bronchial epithelium. In electron microscopic source, then when the viral vesicle particles, you're going to see vesicle particles in the bronchial epithelium. This is ciliated epithelium. This is one of the interesting story in our hospital happened the last year. Okay, this is a couple, a two couple, because they in ESC hospital they closed the system. Okay, there is no OAC because of the coronavirus. Okay, the dean asked to give the donate the fans to the public people. The two people they given the around 200 to 300 fans to the hospital. They doesn't have money. Okay, they given the they pledged a pound to the gold to the shopping. After they given the fans to the hospital. Okay, they have to appreciate it. They have to be appreciated. After that, the donation given to the hospital. One of the patients admitted. After the patient discharged. That patient is told to other patients, the incoming patients told that this is my own fan. Okay, I have to pay, like they told. After that, they get the money from around 800 other patients. Okay, they got the money. This is the unity. And finally, the last slide. Kindly follow the SMS protocol, soap, sanitizer, mask, social distancing. Along with this, they had the vaccination and the ventilation. Open the have a good ventilation. And thank you. Now, I would like to thank to institution, Vivekananda institution, for giving a wonderful opportunity for presenting this topic. Also, want to thank you for Saranya ma'am. Thank you. Any doubts, please?
Thank you so much, sir. Now, if any queries, please raise your hands and we'll move on to the next presentation. If there are no queries, then we'll move on to the next presentation. We welcome Dr. Bhuvaneshwari ma'am
Thank you,
for the
ma'am.
next presentation.
Thank you all.
Hello, good morning all. Is my screen visible?
Good morning, ma'am.
Yeah,
Yeah,
is my
your
screen visible?
screen is visible.
Okay, ma'am. I'm Dr. Bhuvaneshwari. Today I'm going to talk to you about role of radiology in this COVID pandemic. Coronavirus disease caused by the novel enveloped single-stranded RNA has emerged as a pandemic, as we are well aware now, which led to a global public health crisis of unprecedented magnitude of mortality and morbidity. The disease progresses asymptomatically in majority of the cases, which is fortunate for us, with the presentation of fever and upper respiratory infection symptoms. However, in the presence of comorbid diseases or advancing age, the disease may aggravate and leads to complications such as pneumonia, acute respiratory distress syndrome, multi-organ failure, death, depending on the degree of diffuse alveolar damage and inflammatory response. Radiology plays a significant role in finding these cases. The severity of COVID pneumonia cannot be determined by RT-PCR. Therefore, it is necessary to conduct a complementary radiological study. Chest X-ray is the frequent modality used as due to the low cost and wide availability in everywhere, which allows various conditions to be studied in a fast manner. It is mainly used as a method of screening whether the patient has or has not pneumonia to the severe level. So, and the disease severity assessment can be done with chest X-ray at initial presentation. And as nowadays we have portable radiograph X-ray machines, we can shift that to the patient's bedside when in ICU or anywhere, and we can get adequate information on the lung findings in addition to the lines and tubes, like whether the patient has endotracheal tube or central line. So that sort of information can also be additionally got with X-ray. And potential complications like pneumothorax can also be assessed with the bedside X-ray itself. And sometimes it is the only possible modality in severe infection cases because patients will be very severely ill. They cannot be mobilized to another location for a CT or other investigations. The most common X-ray findings in COVID are bilateral findings, ground glass opacities, consolidation, which then progresses to reticular opacities. In few cases, we also had pneumothorax, pneumomediastinum, developing pleural effusion, and even lung cavitation. But the predominant findings are ground glass opacities and consolidation. For example, this X-ray belonged to an 82-year-old woman who presented with cough, shortness of breath, and altered mental status. This was taken on the day one. We can see here there is involvement of the right lower lobe lung. 2 days later, she developed worsening respiratory function and confusion. The patient was shifted to ICU and again intubated. The repeat X-ray showed increasing opacities in both lung fields, as we can see, and developing left pleural effusion. So X-ray helped in both initial time and then follow-up even at the bedside. This case was belonging to this X-ray belongs to an 83-year-old man who was known coronary artery disease patient. He had mitral insufficiency, was operated. As we can see the sutures, sternotomy sutures in here. Now he presented with COVID infection. Here we can see the ground glass opacification and in the right upper lobe, and here also we can see the ground glass opacity haziness in the left lower lobe, which is developing as a consolidation. So this suggests he has lung involvement in COVID. Mainly, our role of X-ray is to follow up in severe cases because as in this case at admission, this patient had multiple patches of opacities in both lung fields. She was a very old lady directly admitted to ICU due to low saturation and physically very ill. At the follow-up was done at frequent interval as in 4 hours, 24 hours, 48 hours, and 72 hours. So here we can see the increasing amount of opacification, consolidation, or as the time passes. And here, full involvement of the lung fields is seen. As for example, I have shown here the normal X-ray, how clear it is, but we can see how much the lung have involved as if no residual normal lung parenchyma is seen. That is nearly 80 to 90% of lung involvement was present in this case. And later on at 72 hours, she developed full-blown ARDS, and then patient passed away. But a word about caution regarding X-ray is it cannot detect subtle changes in the early phase of the disease. For example, herein we have a case which showed ground glass opacity with vascular dilatation, microcavitation in the peripheral right lower lobe, that is suggestive of COVID infection. But in this X-ray, we cannot see any of the such changes. But these two studies were done just 1 hour apart. The X-ray was done 1 hour before the CT picture, but we cannot see any findings here. So it is the inherent limitation of the modality. X-rays cannot detect early subtle changes. So in those cases, CT comes in handy. CT plays a major role in triaging of the patients, whether the patient has COVID pneumonia or not. If he has a suspicion of a pneumonia, we can stage the disease severity, whether the involvement is mild, moderate, or severe category based on multiple CT scoring systems. How much percentage of lung is involved, whether 20%, 50%, and in some extreme cases, we had even see 100% of the lung involvement. So that can be possible. That triaging is made with CT, and it predicts the worsening or improvement of the patient's physical condition based on the amount of lung involvement. CT comes as a problem solver in a clinically suspicious cases wherein the patient presents with symptoms of COVID, but the RT-PCR turns negative. In such scenario, CT helps in finding out whether he has involvement in lung or not. The most common patterns in CT are ground glass opacification in bilateral lungs, most predominantly in the posterior distribution with multilobar involvement and peripheral distribution in the early phases, which develops into consolidation as the disease progresses. These are the various signs or patterns in COVID pneumonia. If we find any of these, we suggest it as a COVID involvement in the lung. For example, we describe this as a ground glass opacification, peripheral subpleural location in the right lower lobe. And in this case, we can see multilobar involvement, such ground glass opacification in left lower lobe. This is in the left upper lobe, and here also a subtle change in the right upper lobe. So this is multilobar involvement. Here we see ground glass opacification along with septal thickening, that is crazy paving. We name it as crazy paving, which on progress leads to increased density with air bronchogram as consolidation. Here we see halo sign, that is central high dense region with peripheral less dense areas, that is known as halo sign. This is a reverse halo sign wherein there will be central low dense area surrounded by a peripheral high dense region, that is reverse halo sign. These two are ulta, so this is called as reverse halo sign or atoll sign. Herein we can see a vascular sign, that is within the lesion, that is the ground glass area, the vessel will be more prominent than compared to the vessel in the other normal uninvolved segments. Herein we can see microcavitation and early reticular band formation. Here also we see the band is getting more denser and thicker. So these are the stages of fibrosis where we can see thick fibrous bands. So if any of these findings with clinical suspicion we suggest it as COVID pneumonia. For example, in this scenario, this patient presented with 5 days of fever, wherein on day 3, he tested for RT-PCR, but the result came as negative. Still, after 5 days, he having continuous fever. So the clinician suspected COVID in this pandemic. So he referred to CT. In CT, we can see ground glass opacification in multiple areas, predominantly in the posterior segments, evolving into consolidation, microcavitation, as I have shown earlier. These are classic of COVID involvement. Although the RT-PCR came negative for him, we diagnosed it as COVID and started on treatment. Later, 2 days after that, he had a repeat RT-PCR, which came as positive. So in such scenarios, wherein a clinical suspicion is there and patient has symptoms consistent of COVID, even though RT-PCR comes negative, we can start treatment based on this COVID involvement on the CT findings. CT, it changes, evolves over the time, the stage of disease. We mainly categorize into 4 stages: early stage, progressive stage, peak stage, and absorption stage. In the first 4 days of the symptoms, that is, we have ground glass opacification, partial crazy paving appearances, and with minimal number of lobes involved. Totally, we have 5 lobes, including both the lungs. In initial stages, the patient may present with 1 or 2 lobes involved. On progressive stage, 5 to 8 days of the disease, the patient will have extension of the ground glass opacification and increasing in the crazy paving pattern with more surface area of the lung getting involved. Multiple lobes can be involved in this progressive stage. In peak stage, almost all the lobes are involved and it progresses to consolidation, that is, increase in the density, and the lung is getting more and more affected. It is commonly seen in 10 to 14 days of the disease. And after the 2 weeks, it is called as absorption stage. We start seeing findings of gradual resolution, as in fibrosis and reticular bands. So based on CT, we can categorize them, which stage they are in. For example, I have shown here a case with the early phase involvement. We can see multiple patches of ground glass opacities in both central and peripheral distribution involving almost all the lobes, but he don't have any consolidation or reticular fibers. This suggests he has moderate involvement of both lung fields, but he is in early phase of the COVID. So treatment can be categorized according to that. This belongs to another patient who had multiple lobar involvement like in previous case, but he has started developing thin reticular bands and along with consolidation within both the lung fields. So this suggestive of consolidation with air bronchogram, all the findings, mixture of findings, that is, he is in the peak stage, late peak stage, with early appearances of resolution findings are seen here. So we can decide upon how to proceed based on this details. And this belongs to a patient in the absorption stage. That is, he has crossed more than 2 weeks. The lung involvement is getting changes of absorption like fibrosis, thick fibrous bands, subpleural arcades are seen here, along with resolving consolidation. So mostly, though the radiologically the more surface area of lung is involved, he started showing resolution changes. So he won't be that bad clinically. These information can all be got with CT. There are certain poor prognostic signs on CT, such as widespread consolidation areas, that is, surface area of the lung involved will be more than 50%. We have a widespread consolidated areas, rapid infiltration into the upper lobes, developing pleural effusion and mediastinal lymphadenopathy. Rare findings such as diffuse involvement, structural distortion, traction bronchiectasis, intrathoracic lymph nodes, and pleural effusion are more common in the critically ill patients. When we see a multiple lobe involvement, subsegmental consolidation, we can suggest this patient will need intensive care. CT is decisive in follow-up and treatment algorithm in such areas. Coming to the systemic involvement, although we know COVID predominantly affects the respiratory system, it has become apparent that many other organ systems are involved. A comprehensive understanding of the diagnostic imaging features, multi-system involvement, evolution of the imaging findings are essential in the patient management. These include myocardial dysfunction, arrhythmia, acute coronary syndromes, acute kidney injury, gastrointestinal symptoms, hepatocellular injury, hyperglycemia, ketosis, neurological illness like stroke, vasculitis, bleed, encephalitis, ocular symptoms, and dermatological complications can all be detected with imaging. Such widespread involvement of multiple body systems is attributable to the expression of ACE2 receptors. For example, in this case, this belongs to a 68-year-old man who presented with acute weakness on the left side of his body for 3 days. He was diagnosed with COVID-19. This plain CT brain shows multiple areas of hypodensities, which are suggestive of acute infarcts in the right middle cerebral artery territory. So it is an acute thrombosis of right middle cerebral artery territory due to COVID infection. This case, we can see a 72-year-old man in ICU who had developed right arm swelling after the diagnosis of COVID. We did a Doppler ultrasound in his right arm, which showed an occlusive thrombus in the right brachial vein, and here we can see the thrombus in the right basilic vein. So he had both deep and superficial venous thrombosis due to COVID disease. As we all know, COVID is a prothrombotic state in this patient with the COVID pneumonia, a 62-year-old man who presented with a severe hypoxia and elevated D-dimer levels. On CT contrast, we could see a non-enhancing central thrombus within the right ventricle. So he has a thrombotic state. It was very acute stage. Various gastrointestinal manifestations like gastritis and colitis were seen in patients presenting with COVID. For example, this patient had epigastric pain. This is the stomach, which shows edematous mucosal thickening and mucosal hyperenhancement, suggestive of gastritis in a COVID patient. And in this case, we can see the colon, ascending colon, is thickened and shows mucosal enhancement suggestive of colitis. So COVID presents with abdominal symptoms also. Herein, we have an 85-year-old male patient who was COVID pneumonia positive, who developed hematuria and acute renal failure. We did an ultrasound abdomen, and in his urinary bladder showed a non-enhancing thrombus within the lumen, suggestive of he's having hemorrhage, acute hemorrhage going on. And this is the image of a Neuro Sonogram, a 2-day-old full-term newborn born to a COVID positive woman by cesarean delivery. The baby developed coagulopathy symptoms. We did the ultrasound cranium, and this shows hyperechoic regions within both the thalamus, which is suggestive of hypoxic ischemic encephalopathy, and the baby had other multiple organ system involvement. Finally, the baby died. And herein we see a 23-year-old male who has severe blepharoptosis with the corneal edema, conjunctival chemosis, and lacrimation. And we proceeded with the CT, PNS, and brain, wherein we can see the left hemifacial soft tissue shows thickening with inflammatory signs. This is the left eyeball, which shows anteroposterior elongation. This is the normal shape of the eyeball on the right. The left involved eyeball shows anteroposterior elongation suggestive of proptosis, and the preseptal region shows fluid collection. Premaxillary region also shows evidence of inflammation, with the left maxillary sinus showing fluid level suggestive of sinus involvement also in this case. So this is a case of invasive fungal sinusitis, which has maxillary sinus involvement, orbital involvement, and intracranial extension, which is confirmed with the MRI image. This MRI brain image shows his frontal lobe involved lesions, and his MR angiographic image, which images the intracranial vessels, shows thrombotic occlusion of the left internal carotid artery. Herein we can see the normal internal carotid artery. Here we don't see such a normal appearance suggestive of thrombotic internal carotid artery. In the same patient, we had cavernous sinus thrombosis. This is the normal cavernous sinus on the right side. On the left side, we don't see any enhancing normal cavernous sinus suggestive of thrombosis. So this patient had mucormycosis with rhino-sinonasal involvement, cerebral extension. So he was taken up for surgery immediately. And a word about the treatment algorithm. If a patient presents to us with symptoms suspicious of COVID, first we have to do a physical examination. If he has any serious clinical condition or pneumonia, we can directly hospitalize them and right away do the lab test biomarkers, chest X-ray, and if available, CT at the instant. And then based on that, we can start the treatment right away. because RT-PCR results can take some time. So we don't have to wait until that. If any of these are present, clinically suspicious patient and having findings in the chest X-ray, CT or lab parameters, we can right away start the treatment. Then we can confirm with RT-PCR findings and we can continue the treatment. If RT-PCR comes negative, we can do two things. One, we can repeat the test to confirm the COVID. If repeat test is also negative, we can see for other diseases like bacterial or viral other than COVID infection. So that also can be imaged with CT. And if the patient doesn't have any serious clinical condition or pneumonia, we can ask for the age of the patient and any comorbidities. If the patient is elderly, having any comorbid disease, we can hospitalize them and follow the protocol starting treatment. If none of these are present, we can treat them on OPD outpatient basis with lab parameters and chest X-ray results. If any of the results came as positive, we can take as the patient is having COVID involvement and start at hospitalization and treatment there. If nothing is there, we can wait for the PCR results. And if it is negative, we can suggest them 14 days home isolation and follow up. If the patient turns as PCR positive, we can start treatment as a mild case because they don't have any serious clinical condition and imaging was also they. So we can start the treatment right away. So this protocol helped us a lot in this pandemic. Take home message finally, the PCR test is very specific as we all know, but due to the variable sensitivity ranging from 60 to 95%, imaging is crucial in such scenarios. Chest film is useful in pediatric cases and in follow-up of the known COVID cases. CT is not indicated in patients with mild features unless they are at risk for disease progression. CT is indicated in patients with COVID-19 with worsening respiratory status or any comorbid conditions or elderly patients. The first goal in CT imaging is to detect whether the patient has COVID pneumonia or not. And if he has involvement of lungs by the COVID, we have to differentiate and stage them, whether they belong to mild, moderate, or severe categories, and at which stage, early or late stage of presentation, we can identify with CT. Triaging of the patients into mild, moderate, severe category, along with clinical features and lab biomarkers is essential. Imaging plays an essential role in the diagnosis of all the systemic manifestations of COVID, as well as its related complications. Thank you all. I thank the organizers for giving me such a good opportunity. I thank the audience for your patient listening too. Thank you. Do we have any questions, ma'am?
Thank you, ma'am. If there is no queries, then we'll move to the next session. How capable are we of finding the solution if we don't know its pathophysiology? Thank you, sir. Your session was eye-opening. A correct diagnosis is 3/4 the remedy. Thank you, ma'am, for your eye-opening session. Next, let's move on to the next session. Now, Dr. Arul Raja sir, HOD, Department of Pharmacology, will introduce the speaker for the next session.
Yes. Good afternoon to all. Thank you everyone for being with us for a long time. On behalf of Vivekananda Dental College, I welcome our resource person, Dr. R. Saravanan, to deliver his talk for the next session. And I am very pleased to read his profile. He had finished his UG in Vinayaka Mission's Homeopathy Medical College. He had undergone his master's MSc Medical Pharmacology at Kasturba Medical College, Manipal. Also, finished his doctorate in pharmacology at Vinayaka Mission's University, Salem. He has over 12 years of teaching experience and currently working as an associate professor in RVS Dental College, Coimbatore. He has been awarded for his academic excellence in pharmacology at Kasturba Medical College, Manipal on the year 2011. He had published his papers in various international and national journals, also presented many papers at national and international conferences. Thank you all for this opportunity. Now, I request Dr. Saravanan sir to take over the session.
Good afternoon, everyone gathered here. Is it audible? Is it audible? Dr. Arul Raja, is it audible? Okay. So thank you, Dr. Arul Raja, for your very warm introduction and a kind gesture. So it was a wonderful and very informative session by the previous two speakers, Dr. Tirunavakarasu, Dr. Bhuneshwari ma'am, and Dr. Sendil. So it was my privilege to be a part of this online CDE program organized by the Vivekananda Dental College. So thanks to the organizers, the principal and the management of Vivekananda Dental College for Women for having me here. So now, before I move on to my topic, that is potential targets in SARS-CoV-2, so I'd like to share a few brief introduction about coronavirus. So as we all know, the coronavirus disease is defined as the illness that is caused by the novel coronavirus, which we call it as novel COVID-19. So the coronavirus study group of the International Committee on Taxonomy of Viruses has renamed that as SARS-CoV, that is Severe Acute Respiratory Syndrome, SARS-CoV-2. In the past 2 decades, there were 2 more coronavirus outbreaks that has caused severe respiratory diseases. The first one is to severe acute respiratory syndrome coronavirus, that is SARS-CoV-1 in the year 2002 in Guangdong province of China. The second outbreak of coronavirus is Middle East Respiratory Syndrome coronavirus, MERS-CoV, in the year 2012 in Saudi Arabia. And now we are experiencing the third outbreak of coronavirus in the year 2019 called as SARS-CoV-2. So let us see the life cycle of the virus briefly so that it will be supportive for me to explain the potential targets. So the infection is initiated by the binding of the spike proteins of the coronavirus to the human angiotensin converting enzyme 2 receptor binding domain. So once the virus binds, so there will be activation and endocytosis of the virus. Okay, so if we look into the locations where this human ACE2 receptors are present, they are present in the target cells of nasal, bronchial, epithelial cells, as well as in the pneumocytes of the lungs. So the dissemination of SARS-CoV-2 in other areas, that is extrapulmonary sites, is due to the wide cellular distribution of ACE2 receptors in the GIT, in cardiovascular system, in central nervous system, and urogenital system. So once the virus binds to the ACE2 receptor, it can enter the host cell or the human cell by two methods. The one is endocytosis mediated entry, the other one is TMPRSS2 mediated entry. So TMPRSS2, as already discussed by the microbiologist, so it is a transmembrane protease serine 2, which is helping in the endocytosis of the virus. So once the virus enters into the human cell, there is a process of fusion and uncoating of the viral genome, into the host cell. So here the 2/3 of the viral genome is contained in the first open reading frame of the viral genome. So this open reading frame, the first open reading frame, encodes for the synthesis of polyproteins and many other non-structural proteins. So let us see, this non-structural proteins are nothing but the enzymes which are mainly involved in viral replication. So one of the non-structural protein that is synthesized is RNA-dependent RNA polymerase. So once the polyproteins and non-structural proteins are synthesized, they will be cleaved into individual functional subunits, so which then takes up the role of replicase transcriptase complex, and the viral genome will make multiple copies of the viral RNA, which later will be assembled with the accessory proteins and the structural proteins, which are encoded by the other open reading frames that are present in the viral genome. So this completes the synthesis of proteins and other viral RNA which is needed for the virus multiplication, and finally the process of exocytosis releases the virus to the exterior. So coming to the pharmacological part, so drugs can target the human ACE2 receptors so that the binding of spike protein to the ACE2 receptor can be inhibited. The second possibility is that inhibiting the TMPRSS2, the protease enzyme, that is the proteolytic enzyme which is needed for the cleavage or binding of the spike protein to the host cell membrane. The third target will be the proteolytic enzymes of the virus, So without the proteolytic enzymes of the virus, the viral polyproteins which are synthesized from the open reading frame cannot be cleaved into the individual functional components. So without the functional components of protein, the virus cannot multiply and the viral multiplication will be arrested. So now going to the potential targets of SARS-CoV-2. So the first one is targeting the receptor proteins on the host cell surface, of the host cell, which is nothing but the human ACE2 receptors which are present on the surface of the target host cells, that is nasal and bronchial epithelial cells and the pneumocytes of lung. So blocking this human ACE2 receptors will deny the viral entry into the human cells. The second target, what we are going to see, one second. The second target what we are going to see for today is the proteolytic enzymes. So these are the host proteolytic enzymes, that is TMPRSS2, cathepsin L and furin. So we have seen the role of TMPRSS2. Now we are going to see the role of cathepsin and furin, how it is helping in binding and uncoating of the viral genome into the human cells. So this is to show that the coronavirus spike protein, the S protein, binds to the human ACE2 receptors. So after the binding has taken place, there are two ways by which the virus enters into the human cell. So the first one is endosome, that is endosome mediated entry of virus into the human cell. The second method is TMPRSS2 mediated activation of spike protein and fusion of the coronavirus to the host cell membrane and direct release of the viral genome into the host cell. So coming to the first method, the entry of virus by the process of endocytosis. So once the virus enters into the host cell, so the virus is present inside the endosome, so which is covered by the endosomal membrane. So there are two proteins, that is furin and cathepsin, doing a two-stage cleavage of the spike protein, which is needed for the release, that is binding of the spike protein to the endosomal membrane and uncoating process. So the spike protein contains two subunits, S1 and S2. So the S1 subunit is helping in the binding of spike protein to the human ACE2 receptors. The subunit 2, that is S2 subunit, is actually helping in binding of the coronavirus to the endosomal membrane. So the first protein, that is furin, the proteolytic enzyme, furin, will cleave the S1 and S2 subunits of the coronavirus. So by cleavage of S1, S2 compartment, the S2 segment or the S2 subunit is exposed outside. So this leads to the exposure of S2 subunit. So now cathepsin L will further cleave the S2 subunit for the activation of the S2 subunit and binding of S2 subunit to the endosomal membrane. So once the spike protein S2 and the endosomal membrane fusion takes place, there will be release of the viral genome into the host cell. So later on, there will be multiplication by the replicase transcriptase complex and the mature virus will be released outside. So now the third target which we are going to see is the targeting the non-structural proteins like 3 chymotrypsin-like proteases and papain-like proteases. There are also other non-structural proteins like 1, 2, 3 non-structural protein 7 to 8 complex which are needed for the viral replication to take place. So this is the first open reading frame that we were talking about, which encodes for the synthesis of polyproteins and non-structural proteins. So these non-structural proteins are synthesized as a long polyprotein. So there are approximately around 16 non-structural proteins that are synthesized from the first open reading frame of the viral genome. So later, this is a non-functional protein. This need to be cleaved into individual functional subunits so that the further multiplication process can take place. So there are two main proteases, that is papain-like protease and 3 chymotrypsin-like protease, which cleaves the 16 non-structural proteins into 16 functional compartments. So initially there is a intracellular autoproteolytic activity taking place, cleaving the 3 chymotrypsin-like protease and papain-like protease. So once these two proteases are released, they further cleave the non-structural proteins into individual compartments. So the papain-like protease cleaves the non-structural protein 1, 2 and 3 and 3 chymotrypsin-like protease cleaves the other proteins from 5 to 16 into 11 individual functional proteins. So later on, once the process is completed, so there will be maturation and release of virus into the exterior. The next target is suppressing the viral replication process by inhibiting the main enzyme, that is RNA-dependent RNA polymerase. The next target will be targeting proteins like helicases, N-terminal RNA binding domain, C-terminal RNA binding domain. And the last one is blocking the signaling pathways involved in viral replication and assembly process of the viral particles to make it virulent. And it is also blocking the signaling pathways that are involved in inhibition of the host's innate immune mechanisms. So now let us see what is repurposing of drugs. So repurposing is nothing but drug repurposing involves uncovering of the existing therapeutic agents for the treatment of new infections, okay, or for the approval of new therapeutic indication. So agents which were previously used for the management of SARS-CoV-1 and MERS-CoV are and other antiviral drugs and anti-helminthic drugs are repurposed for the purpose of treating COVID-19 infections. So up to date, there is no single entity which can completely treat COVID-19 infection. So drug repurposing has become a model for the rapid development of drug against infectious diseases, especially in case of global emergency like SARS-CoV-2 infection. So it allows not only saving time, it also reduces the cost-effective approach for the development of new drugs. So now we are going to see the categories of drugs which are available for the management of COVID-19 infection. So based on their mechanism of action, they are divided into different categories. The first one is inhibitors of viral replication. So that is nothing but drugs that inhibits the RNA dependent RNA polymerase enzymes. So ribavirin, remdesivir, favipiravir, molnupiravir, emtricitabine in combination with the tenofovir and oseltamivir are the drugs that are available approved for the management of COVID-19 infections. The second category of drugs include drugs that inhibit the viral replicases, the viral proteolytic enzymes. So we have drugs like, one second, the slide is not moving. Yeah. So lopinavir, ritonavir, darunavir, dolutegravir, atazanavir, noscapin, and the recently added drug that is nirmatrelvir and ritonavir combination. So all these drugs, they mainly inhibit the main protease enzymes. So here the main proteases are nothing but the 3-chymotrypsin like protease and peptide like protease, which are involved in cleaving the non-structural polyproteins into individual functional compartments. So by inhibiting the main proteases, it prevents the formation of mature infectious virus particles for the replication. The next one is inhibitors of viral entry into the host cell. So Biracitonif, Roxolatinib, Umifenovir, Bromaxin, recombinant human ACE2 receptor, then Ensovibep. So all these drugs, the first three at least, will inhibit the pathways, the signaling pathways that are involved in endocytosis mediated entry, as well as their activation in the innate immune system. So the next one is immunostimulant agents like interferon alpha and beta, nivolumab and levamisole. The next one is immunomodulating agents like intravenous immunoglobulin or convalescent plasma. Then thalidomide, which was a teratogenic drug but still was under pipeline in clinical trials for the management of COVID-19 infections. The next one is sotrovimab, which is a human neutralizing monoclonal antibody against spike proteins, and casirivimab and indevimab are recombinant a combination of two recombinant monoclonal antibodies targeting against the spike proteins. And the next one is immunosuppressive and anti-inflammatory substances like corticosteroids, tocilizumab, sarilumab, siltuximab, NSAIDs and anakinra. So all these, they will inhibit the third stage of coronavirus infection, that is cytokine release syndrome, because the cytokines interleukin 1 to 17 and other cytokines are mainly involved in progression of the disease to the third stage, that is hyperinflammatory stage of the disease. And the last category of drugs that are available is pulmonary vasoeffectors, that is nitric oxide, sildenafil, avibdatal, bevacizumab and losartan. So now coming to the individual drugs and their mechanism of action. So the first one is inhibitors of viral replication, remdesivir. The very commonly used drug and extensively used drug in the management of COVID-19 infection is remdesivir. So remdesivir is a monophosphamide prodrug. Remdesivir is a monophosphamide prodrug and adenosine nucleotide. So which is actually developed as a drug of choice for the treatment of Ebola virus. But later on, it was very effectively used during the first two outbreaks of coronavirus, that is SARS-CoV-1 and MERS-CoV. And at present, it has been employed in the treatment of SARS coronavirus infection 2. So as I said, it is a prodrug. It need to be converted into an active metabolite. So the active metabolite of remdesivir is remdesivir triphosphate. Remdesivir triphosphate. So after the conversion of the remdesivir prodrug into the active metabolite, all the actions of remdesivir is due to the metabolite that is formed. So let us see the mechanism how remdesivir is helping in treating COVID-19 infection. So the first mechanism is by inhibiting the viral RNA-dependent RNA polymerase enzyme. So this is a key enzyme that is needed for the viral RNA to multiply, to replicate. So by inhibiting the RNA-dependent RNA polymerase enzyme, it inhibits the viral replication and viral RNA synthesis. The second mechanism is, so as it is a adenosine nucleotide analog, it competes with ATP for its incorporation into the viral RNA. So this is easily done by the error-prone RNA-dependent RNA polymerase. So during multiplication, in the presence of remdesivir, RNA-dependent RNA polymerase will mistakenly take up the remdesivir triphosphate and insert it into the viral RNA. So which leads to the chain termination or accumulation of deleterious mutation in the viral genome. The third mechanism is by inhibiting several target viral proteins, which includes the non-structural protein 3B, E channels, and TMPRSS2 proteolytic enzymes. Coming to the actions of remdesivir. So remdesivir is a broad antiviral drug which was effective against a number of RNA viruses like Ebola virus, SARS-CoV-1, MERS-CoV, Marburg virus, Nipah virus, respiratory syncytial virus, and Hedra virus. And now it is being employed in the management of COVID-19 infection. In COVID-19, during clinical trials, it has been shown to reduce the viral load in the lung tissue, and it has improved the lung function of the COVID-19 infected individuals. So it has been approved by the US FDA for the management of COVID-19 in adults, pediatrics, as well as in third trimester pregnancy. So the dosage is intravenous infusion of 200 mg of loading dose followed by 100 milligram of maintenance dose for a period of 5 to 10 days. Coming to the second drug of the same group, that is inhibitors of viral replication, favipiravir. So favipiravir, similar to remdesivir, is also a prodrug which needs to be converted into an active form. So favipiravir prodrug gets converted into the active favipiravir ribofuranosyl triphosphate, favipiravir RTP, by the cellular enzyme, intracellular enzyme, hypoxanthine guanine phosphoribosyl transferase. So once the active metabolite is formed, the mechanism is similar to that of the remdesivir. So they inhibit the RNA-dependent RNA polymerase enzyme, and it also gets falsely incorporated in place of ATP in the viral genome by the error-prone RNA-dependent RNA polymerase. So which leads to the chain termination or accumulation of deleterious mutations. The incorporation of favipiravir RTP into the viral genome, if two molecules of favipiravir RTP gets inserted or incorporated into the viral RNA, there will be a complete blockade of extension of the RNA strand, which leads to complete viral replication process. So actions of favipiravir is similar to that of remdesivir, that is they have a wide antiviral activity against a number of RNA viruses. So influenza virus, arena virus, bunya virus, Rift Valley virus, yellow fever, foot and mouth disease, plebovirus, norovirus, and avian influenza viruses are the viruses that are targeted by favipiravir. They are also effective in SARS-CoV infection 1, SARS-CoV-2, Ebola virus, Lassa virus, and hantavirus. So it is found to be very effective in reducing the viral load in lung tissues. So the dosage of favipiravir is 1800 milligram, which is given as a loading dose, followed by 800 milligram twice daily for a period of 2 to 14 days orally. So the main difference between the remdesivir and favipiravir is that favipiravir can be taken orally, whereas remdesivir need to be given by intravenous infusion. And the next important difference between remdesivir and favipiravir is that favipiravir is not allowed or approved for the usage in pregnancy. It is contraindicated for the usage in pregnancy. So adverse effects like GI distress, raised uric acid level, abnormal liver function test, raised triglycerides, and psychiatric reactions are commonly seen in favipiravir treatment. The third drug, which was recently added to the protocol of US FDA's protocol of COVID-19 management, is molnupiravir. So which is again a prodrug which needs to be converted into an active metabolite, that is molnupiravir N-hydroxycytidine triphosphate. So once the active metabolite is formed, this metabolite will, similar to remdesivir, will get incorporated into the viral RNA. So once the viral RNA it gets incorporated, it causes chain termination and other deleterious mutations to take place. The main important feature of molnupiravir triphosphate is that molnupiravir can swap between two forms, which is called as tautomers. So one of which will mimic cytidine, the other one will mimic uridine. So the molnupiravir can get inserted into the viral RNA in two places. So when the viral RNA polymerase attempts to make copies of RNA containing molnupiravir, it sometimes interprets it as cytidine and sometimes it interprets it as uridine. So this causes more mutation in all the downstream copies of viral RNA than the viral RNA can survive. So this effect is called as the viral error catastrophe or lethal mutagenesis. So this is the site where the molnupiravir can act. That is RNA dependent RNA polymerase. Not only molnupiravir, remdesivir and favipiravir also acts at the enzyme RNA dependent RNA polymerase. So molnupiravir is not authorized for usage below 18 years because they affect the bone and cartilage growth. But remember, molnupiravir is more effective compared to remdesivir, and it is available in the form of an oral medication, unlike remdesivir, which is intravenous infusion. So the dosage is 800 milligram orally for a period of 5 days. So it was approved by UK and US FDA for the use for emergency use authorization in COVID-19 infection. But in January 2022, India has declined to add it into the national protocol for the management of COVID-19 infection. So that means in India, molnupiravir is not available for the management of COVID-19 infections. So coming to the second category of drugs that are effective against novel coronavirus, that is inhibitors of viral proteases. So lopinavir, ritonavir, it is a combination of two drugs, that is lopinavir and ritonavir. So both the drugs are active, both the drugs are antivirals and that are effective against coronaviruses. So they inhibit the main protease, that is 3-chymotrypsin like protease of SARS-CoV-1 MERS-CoV disease, and now it is being employed for the management of SARS-CoV-2. So lopinavir and ritonavir, they inhibit the main proteases, which are key enzymes involved in viral replication. So I have already told you that main proteases are 3-chymotrypsin like protease and peptide like protease. So lopinavir and ritonavir, apart from inhibiting the main proteases, they also target non-structural protein 3b, helicases, and N-terminal RNA binding domain. And ritonavir can possibly target non-structural protein 3C and E channels. So lopinavir-ritonavir combination can block the viral multiplication cycle and reduce the viral load in the infected individuals. So this is again the same picture which I had shown you before. So the main proteases, that is key 3 chymotrypsin-like protease and peptide-like protease, are needed for the cleavage of non-structural proteins, polyproteins, into individual functional compartments. So by inhibiting the main proteases, the functional proteins cannot be formed, without which the virus cannot multiply. The maturation and the viral RNA replication will be arrested. So the dosage of lopinavir-ritonavir is 400 mg of lopinavir and 100 mg of ritonavir twice daily for a period of 14 days. So adverse effects like GI distress, hepatotoxicity, increased bilirubin level, and cardiac arrhythmia due to QT prolongation are commonly seen. Now coming to the second drug, that is Darunavar. So Darunavar is a HIV protease inhibitor which is used for the treatment of HIV infection, as found to be effective in treating SARS-CoV-2 infection also. So it is approved for usage in SARS-CoV-2 in combination with cobicistat, which is again an antiviral drug, but for the usage or the rationale for adding cobicistat with the Darunavar is that cobicistat is an enzyme inhibitor which inhibits the cytochrome P450 enzyme, which is involved in metabolism of Darunavir, so that this combination will be available for action for a longer time. The duration of action can be prolonged by adding Darunavir with cobicistat. So the mechanism of action, they inhibit the main proteases, that is peptide-like protease and 3 chymotrypsin-like protease. So the second mechanism by which this drug is acting is by disrupting the binding of the SARS coronavirus receptor binding domain human ACE2 receptor. So this disruption will lead to inhibition of recognition of the spike protein to the human ACE2 receptor. So without recognizing and binding, the virus cannot enter into the cell. So FDA has approved the usage in patients with AIDS. Okay, in patients having SARS-CoV-2 in AIDS patients. The next drug that is inhibiting the main protease is nirmatrelvir and ritonavir combination, which was recently added for the management of COVID-19 infection. So nirmatrelvir is nothing but it is a modification of another antiviral drug, lufotrelvir. So lufotrelvir was also very effective in management of COVID-19, which showed promising results during clinical trials. But the main disadvantage with the lufotrelvir is that it needs to be administered intravenously. So nirmatrelvir is a orally active 3 chymotrypsin-like protease inhibitor, which is co-administered with ritonavir. So the main reason for adding ritonavir to nirmatrelvir is that it inhibits the breakdown of the drug and prolongs the duration of action of the second combined drug. So it is available at a dosage of 300 milligrams, 2 tablets containing 150 milligrams each, and 1 tablet of ritonavir 100 milligram. So it need to be taken as a 3 tablets together orally twice daily for a period of 5 days to a maximum of 30 tablets during the complete course of COVID-19 treatment. So this PF07321332 is nothing but the nirmatrelvir, which is inhibiting the main proteases, 3 chymotrypsin-like protease and peptide-like protease, and inhibiting the further replication process of the virus. So coming to the next category, that is drugs that are inhibiting the viral entry into the host cells, Biracitonif. So it is a anti-rheumatic drug used for the management of rheumatoid arthritis, but which was repurposed for the management of COVID-19 infection So it is a JAK, NAC, and GAC inhibitor. So it is Janus kinase, NUMB associated kinase, and cyclin G associated protein kinase inhibitor, which was approved for emergency use authorization in combination with remdesivir in management of COVID-19 infections. So this is the picture to show the role of Biracitonif and how it is helping in inhibiting the viral entry. So once the virus identifies or recognizes the human ACE2 receptor, it binds to the human ACE2 receptor. Later on, there is AP2 associated protein kinase, AP2 associated protein kinase called as AAK1. So AP2 associated protein kinase mediated endocytosis of the virus into the human cell takes place. So along with that, the cyclin G associated protein kinase also helps in endocytosis of the virus into the cell. So Biracitonif, by inhibiting the NUMB associated kinase, that is AAK1 is nothing but it is a subfamily of NUMB associated kinase. So by inhibiting the NUMB associated kinase and the cyclin G associated kinase, Biracitonif prevents the endocytosis mediated entry of virus into the cells. The second mechanism is that, so once the virus is released, the third stage of COVID-19 infection is hyperinflammatory stage. It is also called as the cytokine release syndrome or cytokine storm. That means in the third stage of COVID-19 infection, in the hyperinflammatory stage, there is a large amount of pro-inflammatory cytokines that are released. The pro-inflammatory cytokines include interleukins 1 to 17 and interferon alpha, interferon gamma, and tumor necrosis factors. So Biracitonif, this cytokine storm or cytokine release syndrome is mainly mediated by the JAK-STAT kinase mediated synthesis of cytokines. So Biracitonif, by inhibiting the JAK-STAT kinase pathway, it prevents the cytokine storm development, which is responsible for the development of acute respiratory distress syndrome ARDS and multi-organ failure and death of the individual in COVID-19 infection. So 1 in 6 patients of COVID-19 infection was initially found to develop the cytokine release syndrome, okay, which later on will develop into ARDS and multi-organ failure. Finally, it will end up in death of the COVID-19 infected individual. So Biracitonif, by multiple mechanism of action, it inhibits the entry of virus as well as the cytokine storm that is formed during the third stage of COVID-19 infection. So the same thing is given here. So JAK enzyme mediates the signals from the cell surface receptors for various cytokines and growth factors, okay, which releases the cytokine storm in COVID-19 infection. So the JAK-STAT pathway will also modulate the gene expression and favoring the cytokine release syndrome. So the second mechanism is by inhibiting the NUM associated kinase and cyclin G associated kinase mediated endocytosis of the virus, that is virus entry into the host cell. So the dosage of Biracitonif is 4 mg orally once daily for a period of 14 days. Adverse effects like nausea, GI perforation, rise in LFT, upper respiratory infection, pulmonary embolism, thrombosis, and it is contraindicated in renal insufficiency. The second drug which we are going to see is Roxolatinib, which also inhibits the Janus kinase 1 and 2, which was initially used in the treatment of myelofibrosis, and at present it was repurposed for the management of COVID-19 infections. It blocks the virus in a different pathway. It is not through the NUM associated kinase or cyclin G associated kinase pathway. It is by inhibiting the viral entry or endocytosis by clathrin-mediated endocytosis. A different pathway is used by Roxolatinib for the inhibition of COVID-19 entry. So it probably lowers the hyperinflammatory stage, that is the third stage that is seen in COVID-19 infection, and it prevents the development of acute respiratory distress syndrome. Tofacitinib, sunitinib, and erlotinib are the other Janus kinase inhibitors that are in pipeline in the clinical trials for the management of COVID-19 infections. So the next one is immunosuppressive and anti-inflammatory drugs, which are severe in case of COVID-19 infection, especially in the third stage of disease progression. There will be severe inflammatory response in patients infected with COVID-19. Okay, so let me not go into the details of steroids because the mechanism and other thing is already well known. So in case of COVID-19, dexamethasone was started early in the novel coronavirus induced pneumonia, NCIP, will reduce the need for the mechanical ventilation and it improves the pulmonary parameters. So WHO has recommended dexamethasone or hydrocortisone for the management of COVID-19 infection, which was very extensively used and most of the time life-saving in the first episode of coronavirus infections. The second drug is tocilizumab. As we have seen already, that cytokine storm plays a major role in progressing the disease to the stage of acute respiratory distress syndrome. So interleukin 6 plays a very major role, key role in the development of ARDS. So tocilizumab, by inhibiting the interleukin 6 receptors, it causes a decrease in the severity of the disease. So tocilizumab was approved for emergency use authorization in the management of COVID-19 infection. So the other drugs that were in clinical trials is sarilumab, siltuximab, esulizumab. Actions: tocilizumab causes a reduction in the markers of inflammation. It enhances the negative conversion, that is conversion of swab conversion negative at a very limited time period. It reduces the need for mechanical ventilation in case of ARDS and it improves the respiratory parameters. It reduces mortality in novel coronavirus induced pneumonia and respiratory failure. The dosage of tocilizumab is single IV dose of 8 mg per kg to a maximum of 800 mg along with the dexamethasone is given. The next one is immunomodulating agent, convalescent plasma. This is nothing but the plasma that is isolated from the patient, from the recovering or recovered patient of COVID-19 infection. So convalescent plasma obtained from the recovering patient provides a passive immunity in actively infected individuals. So CP to be collected at least after 14 days of COVID-19 infection. So which will provide a passive immunity to the newly infected individuals. So CP was used before in the prophylaxis of poliomyelitis, measles, mumps, Ebola virus infection, and H1N1 infection. And currently, it was also included in the prophylaxis or treatment of SARS-CoV-2 infection. And US FDA has recently revised the emergency use authorization of convalescent plasma. That is, it should not be used in patients who are having mild symptoms, or if the patient is not hospitalized, or if there is any any severe form of respiratory involvement, this convalescent plasma should not be used in COVID-19 infections. That was the revised emergency use authorization given by FDA. So actions: it provides clinical improvement, reduces the pulmonary lesion and improves oxygenation. It increases the antibody titer and disappearance of SARS-CoV-2 RNA, and better prognosis is seen in patients who are using CP. And the last one is immunosuppressive agent or immunomodulating agent casirivimab and indevimab. So this substance is a combination of two monoclonal antibodies targeting the spike proteins that are involved in COVID-19 attachment into the virus, into the host cell. So by targeting the spike proteins, the viral entry can be inhibited. So casirivimab, indevimab are prophylactically used to reduce the viral load in respiratory tract and limit the disease progression in case of infected individuals. So FDA has approved for the usage of casirivimab and indevimab 600 milligram each for the COVID-19 management. And day before yesterday, US FDA has revoked the usage of casirivimab and indevimab for the management of COVID-19 infection. That is because it did not show any promising improvement in the individual. But other countries like UK is still continuing to use casirivimab and indevimab for the management of COVID-19 infection. So sotrovimab is another substance of the same category, bamlanivimab and etesevimab, which are used for the post-exposure prophylaxis, and tixagevimab and silgavimab are used for pre-exposure prophylaxis of COVID-19 infections. So to summarize, so we have a number of targets where the drugs can bind and inhibit the viral entry or the further processes that occurs from viral entry. So we have camostat and mesylate, which are TMPRSS2 inhibitors, which binds to the protein and inhibits the viral entry. The second drug is umifenovir, which inhibits the spike proteins of the coronavirus so that the viral entry can be inhibited. The third one is Biracitonif, which inhibits the viral proteases which are needed for the proteolytic cleavage of the non-structural proteins into individual compartments. So ritonavir and lopinavir, which are inhibitors of the main proteases, that is 3-chymotrypsin-like protease and papain-like protease, which are needed for the cleavage and usage of the replication process. This ribavirin, favipiravir, remdesivir are the drugs that inhibit the viral RNA-dependent RNA polymerase. So by inhibiting RNA-dependent RNA polymerase, the viral multiplication, that is copies of viral RNA, will not be synthesized, without which the virus will come to a halt. So there are few investigational drugs that are still in pipeline in clinical trials for the management of COVID-19 infection. So camostat, nefamostat, nitazoxanide, niclosamide, levamisole, interferon alpha and beta, avibdatil, a synthetic VIP, bevacizumab, anticoagulants, and colchicine. These are all drugs which are still in clinical trials for the management of COVID-19 infection. So now let us see some of the drugs that were revoked from the usage in COVID-19 protocol. So chloroquine and hydroxychloroquine, which was very extensively used during the first phase of COVID-19 infection, but currently it was removed from the protocol. And azithromycin with or without hydroxychloroquine, ivermectin, doxycycline, lopinavir, ritonavir, zinc and multivitamins are removed from the COVID-19 protocol of US FDA, WHO, as well as the NIH of India. Thank you for patient listening. I once again thank the management and organizers of Vivekananda Dental College for Women for giving me the opportunity. Thank you. And if there is any queries, I'll be happy to answer them.
Thank you, sir. Now the session is open for queries. When you know your risk, you can lower your risk. Thank you, sir, for the wonderful and informative session. Every day, COVID-19 seems to reach a new target and milestone. Nothing in life is to be feared, it is only to be understood. Now it is time to understand more so that we may fear less. How we upgrade our protective measures to hold the line against this virus is the need of the hour. Even the most severe situation can be turned around. Of course, we must exercise caution. The situation can. I thank Dr. Darunavar sir for giving us the insight on COVID variants microbiologically, right from its origin to its evolution and its current variant. I thank Dr. Sendil sir for the high opening session on pathophysiology of COVID current trends. Thank you, Dr. Bhuvaneshwari ma'am, for sharing your valuable clinical experiences and case reports on role of radiology on COVID pandemic. I thank Dr. Saravanan sir for the enlightening session on potential drug targets in SARS coronavirus 2 and introducing us the various groups of drugs in treating coronavirus infection. Over to Dr. Out of thanks.
Am I audible?
Yes, ma'am, you're audible.
Okay, so a very good afternoon to one and all. It gives me an immense pleasure to express our gratitude to all dignitaries assembled online. All reserved and unreserved appreciation goes to the Almighty for making today's day as a remarkable day for us. First of all, I would like to thank our honorable and respected chairman, Vidya Ratna, Professor Dr. M. Karnanidhi sir, for providing us this platform to conduct this CD program today. I would like to extend our gratitude to our honorable and respected Dean Captain Dr. S. Gokulanathan sir for providing us his enormous support, valuable advice and guidance throughout this program. I would also like to express our sincere thanks to our beloved principal, Dr. N. Balan sir, for being our pillar of support in guiding us through the organizing of the CDE program. We are indebted to all the speakers for today, Dr. Tirunavukarasu, Dr. Sendil, Dr. Bhuvaneshwari, and Dr. Saravanan for being a resource of this program and sharing their valuable knowledge and experience with us. I'm sure all of us are enlightened with the knowledge. I would also like to express our sincere gratitude, Dr. G. Purushothaman, CD convener, VDCW, for his timely help and constant support in organizing this program. I extend our sincere thanks to all the HODs and faculties of all departments for supporting us. A special thanks to all our students and to all the participants who have attended this CD program today for your cooperation in making this program a resounding success. I'm extremely thankful to all the people who have worked behind the screens, our non-teaching staffs, OS Mrs. Nalini, Ms. Ramya, Mr. Dore, Mr. Shakti, and Mr. Suresh. I would like to end my word of thanks by this quote. Gratitude is when memory is stored in the heart and not in the mind. Once again, thank you one and all. Have a nice day.